For those of you who are not at the symposium, my name is Sam Patnoe. I'm an informatics programmer from HealthPartners Institute, and today I'm presenting about the Health Trends Across Communities in Minnesota project on behalf of the Minnesota EHR Consortium. And I really can't emphasize that part enough. I'm just the messenger here. This was a huge collaborative effort, and I played a very small part in it, but the showcase on it really goes out to everyone who involved in the project across the consortium, including our partners at Hennepin County and the Center for Community Health, and to the Minnesota Department of Health who funded this project. So with that said, I'll give a quick background on the Minnesota EHR Consortium. It was initially formed in March 2020 in response to COVID-19. The consortium is a partnership of researchers, state agencies, and the 11 largest health systems in the state. The participating health systems are shown here on the right. They cover every region of the state and provide care to over 90% of Minnesota residents. The consortium uses a federated data model, and all the health systems began a coordinated OMOP CDM adoption starting in 2022, thanks again to funding from the state of Minnesota. The adoption of OMOP across the 11 sites was a separate year-long project, so while it only shows up here as one bullet point, that also was a major undertaking that made this project possible. So the Health Trends Across Communities in Minnesota project, called HTAC Minnesota, began in early 2023 as the first project to fully leverage the OMOP CDM across the consortium, and it had the goal there of building a statewide dashboard to provide timely data for public health surveillance, to inform community health needs assessments, and to promote health equity across the state. Earlier this year in March, the HTAC Minnesota dashboard was made publicly available at the link shown here. I'm also going to throw this link in the chat quick, just to make it easier for you all to navigate. The dashboard has prevalence estimates for over 30 health conditions. I'll show a list of those conditions and explain how they were selected and defined after this dashboard overview. The denominators in the dashboard represent distinct patients who received care at any of the consortium health systems within the prior 3 years. And in 2022, the total denominator was over 5.4 million people, just shown on this screenshot here. That's about 93% of the state population. The prevalence on the dashboard represents distinct patients who received a diagnosis for a given condition within the prior 5 years. The dashboard includes breakdowns by race, ethnicity, age, and sex. This image here shows an example of asthma prevalence across those demographics. By geography, you can look at the state level or filter by region, county, and go all the way down to the census tract level. And this was made possible because each system geocoded patient addresses and added a census tract field to the location table. This image here shows an example of hypertension prevalence for one census tract in Minneapolis. The teal bar charts on the right show how the data for that census tract compared to the overall state rates by race, sex, and age, and the state rates are shown there in light blue. The dashboard currently has data for the years 2020 through 2023, and the data are much more timely than typical health survey data since they're refreshed annually. And then 2024 data should be available as soon as March 2025 on the dashboard. The process used for selecting and defining health conditions for the dashboard included 3 main steps. The first step was the Minnesota EHR Consortium worked with the Center for Community Health to identify and prioritize conditions for the dashboard based on the criteria listed here. This process led to the selection of 31 health conditions shown in this table by topic area. And then for each of those selected health conditions, groups of analysts, clinicians, and subject matter experts across the consortium worked to develop standardized OMOP concept sets. These are mainly mapped from existing ICD-10-based algorithms, and they include the standard SNOMED mappings and the non-standard ICD concept mappings. They also account for metadata across the consortium. They're reviewed by clinicians for validity, and they're essentially managed so that each condition is defined uniformly across all the health systems. So now you've seen a preview of the dashboard and know how the conditions were selected and defined. This is a high-level look at the data infrastructure to show how it all works. The central part of this infrastructure are the red boxes in the middle here, which represent each health system's OMOP CDM database. Two customizations that the health systems made in the consortium included adding a census tract column to the location table, which I mentioned while showing those maps, and then adding an observation 2 table for storing flags for external data linkages and for deduplication. Deduplication was important for this project to avoid overestimation of prevalence for conditions, so now I'll provide a more detailed view from the health system perspective to show how that process works. So now we're zooming in on that last visual and seeing how the data flow and how the deduplication process works from the perspective of one health system. So the first step is that each health system creates a de-identified patient level file for their entire patient population and sends it to a central encrypted data shelter using one-way encryption. In the encrypted data shelter, those files are deduplicated and then linked to external data from state programs, represented here by this green box, using privacy-preserving hashing functions. Next, a matched encrypted deduplicated person-level file is then returned to each health system, which is used for populating that observation 2 table, where the flags for external data and deduplication are stored. So if a patient receives care at 2 or more health systems in the consortium, the patient will only be counted at the health system that has complete race data, the most blood pressure measurements in the prior 12 or 36 months, and the most recent year of a diagnosis. Next, because all the systems are using OMOP, a single set of centrally managed R code is run at each health system. That code generates summary counts stratified by all the characteristics of interest that are shown on the dashboard, represented here by this blue box. And then finally, those summary files are submitted and then combined centrally into an aggregated data file that becomes the source for the Power BI dashboard. So in conclusion, the HTAC Minnesota dashboard demonstrates how OMOP can facilitate sharing summary EHR data across an entire state to monitor community health. This QR code will bring you to the dashboard website. There's a lot more resources there, including more descriptions of the code sets and other FAQ sections that can be really helpful. Some of the next steps on this project include adding some new conditions and indicators for 2025. We're also updating and refining our existing concept sets, and this is an annual process to keep things current. And then there are a number of manuscripts that are in the works too, including an overview of the project and then papers specific to certain measures like hypertension and substance use disorder. And this project currently has funding through the state through June 2026. So I'm sure there'll be a lot more to come as well. So I'll try to answer any questions that may have come up in the chat. Otherwise, thanks so much for your time and thanks for the recognition again.